Balancing the risk and benefit of dual platelet inhibition. Definition. Dual platelet inhibition, ASA, and clopidogrel is a generally accepted standard therapy to avoid stent thrombosis. Cardiovascular and cerebrovascular events commonly arise from atherosclerotic plaque rupture that produces platelet activation, thrombus formation, and reduction of blood flow to the brain or heart. The inhibition of platelets with aspirin is effective in the secondary prevention of acute coronary events. Application in medicine. Dual antiplatelet therapy is recommended for 1 year after an acute coronary syndrome, but the effect of longer-term therapy is not clear. Concern exists regarding the balance between reducing the risk of cardiovascular events and the risk of bleeding complications, because bleeding complications are linked to adverse outcomes in patients with an acute coronary syndrome.
With respect to dual antiplatelet therapy, guidelines on both sides of the Atlantic generally say 6 months of dual antiplatelet therapy for elective stenting, but for patients who have acute coronary syndromes treated with or without stenting in general, it's 12 months. That's the anchor, with a class 2B recommendation to continue longer, meaning it can be considered obligate, and it should be considered, I think, but in patients that are at low bleeding risk only. If patients are at high bleeding risk, I think prolonged DAPT is a bad idea beyond what the guideline recommendations that I just said. In particular, even if a patient's at high ischemic risk and high bleeding risk, the high bleeding risk trumps. So I would recommend prolonged DAPT, but again, antiplatelet monotherapy is the way to go there. Now, patients that are high ischemic risk and low bleeding risk, that's a different story. That's where I think protracted DAPT can be considered in appropriately selected patients. The primary antiplatelet agents, at least on an outpatient basis, that one would consider, of course, aspirin. That's the most commonly used, familiar, cheapest antiplatelet agent. And for chronic therapy, 81 milligrams a day is probably the way to go. My own preference is non-enteric coated, but I do know enteric coated is highly prevalent. A little bit of data suggesting that that might interfere in some patients with the absorption and appropriate antiplatelet effects. But in general, 81 milligrams a day, I think, is the way to go for chronic therapy. Of course, in an acute setting, you want to load with 162 or 325 in general. As far as, and that irreversibly inhibits the platelet for its lifespan of 7 to 10 days. As far as the other broad category of oral antiplatelets, I prefer oral ADP receptor antagonists. Which is going into multiple generic forms these days, so the price is dropping there. And Ticagolor, which is also an ADP receptor antagonist. Both Prasugrel and Ticagolor were potent in clopidogrel. Studies show that at least for patients with acute coronary syndromes, they appear to be better. Prasugrel specifically, that better applies to ACS treated with stents from the Triton trial. And for Ticagolor, that better applies for ACS, where in the Plato trial, Ticagolor is found to be superior to clopidogrel, including lower cardiovascular mortality. So for that reason, some have favored Ticagolor as the preferred antiplatelet on top of aspirin in patients with ACS for a year at least. And the Pegasus trial with Ticagolor, a lower dose than the ACS dose, 60 milligrams BID of Ticagolor, 90 BID being the dose for that first ACS. But in Pegasus, patients with prior MI, 1 to 3 years prior, there was a benefit of Ticagolor 60 BID when added to aspirin versus aspirin alone and reducing ischemic events. In all cases, intensifying the regimen raises major bleeding risk, but in those populations, at least it seems to be worth it, that there's a reduction in important ischemic events even beyond the year after ACS. So in general, I'd say for Ticagolor, it's got the most data and in some respects the most robust data. And most recently, we've added to that with Themis and Themis PCI. If you have a patient, this
had a recent ischemic stroke or TIA, what's the next move? What kind of antiplatelet agent should the patient be on going forward? Recent studies have indicated that maybe dual antiplatelet therapy is the way to go. And now in circulation, there is a meta-analysis that shows that that is exactly the correct answer. The researchers studied more than 14 studies, including more than 9,000 patients. And here's what they found. Dual antiplatelet therapy beats monotherapy by decreasing recurrence of stroke and decreasing TIA. There's also an added benefit. The combination of dual antiplatelet therapy also decreased recurrent stroke and ACS. So going forward, it looks like dual antiplatelet therapy is the way to go for your patient with ischemic stroke or TIA, and the cost is relatively small. That is, the cost of bleeding, because there was slightly more bleeding with the dual antiplatelet therapy patients, but not significantly so. For CardioSource, I'm Peter Block.
Pros and cons. In pros, the addition of clopidogrel, example dual antiplatelet therapy, a platelet P2Y12 receptor antagonist produces even greater secondary privation of coronary events in high-risk patients for up to 1 year. Second-generation P2Y12 inhibitors, example prasugrel and ticagrelor, produce further reductions in the risk of ischemic events over the same time frame, albeit with more bleeding complications. And in cons, long-term P2Y12 inhibition increases bleeding risk. Patients without high-risk features for ischemia or with higher bleeding risk will probably not realize much net benefit. Issue applied in Ecuador. In Ecuador, revealed a superiority to 22%, absolute risk reduction 1.4%. In the reduction of events of recurrent ischemic stroke with any antiplatelet treatment modality against aspirin alone. Non-inferiority or equivalence was observed between antiplatelet drugs and aspirin alone, although superiority can be claimed. The security analysis demonstrated two groups of results, one with increased bleeding risk and other group, on the contrary, showed no difference in the global result. A clinical and significant risk reduction, 22%, absolute risk reduction, 1.4%, about the recurrence of ischemic ictus was observed in the group of DAPT, clopidogrel aspirin, against aspirin alone, but with a significant 58% higher risk of bleeding. Absolute risk increment 0.9%. The group of studies with cilostazol versus aspirin showed a superiority in the risk reduction of recurrent ischemic events with cilostazol and also in the bleeding events against aspirin, 32 and 52 respectively, about risk reduction 2.3 and 2.4 respectively. On the other hand, the studies with ticagrelor and diparomo aspirin versus aspirin alone paper exhibit a clinical but no quite significant lower risk reduction in the recurrence of ischemic ictus, but no evidence of difference in the bleeding risk was observed. Finally, the major risk factor that patients present could detonate cardiovascular events and that predict a higher rate of bleeding with platelet inhibition. Moreover, these data do not support a unified concern with respect to excess mortality with dual antiplatelet therapy, but they do remind us of the fragile balance between efficacy and adverse events.
Every year, millions of patients worldwide receive coronary artery stents for the treatment of ischemic heart disease. To prevent stent thrombosis after treatment with a drug-eluting stent, dual antiplatelet therapy with a platelet P2Y12 receptor inhibitor plus aspirin is recommended for 6 months to 1 year. The risks and benefits of treatment beyond 1 year have remained uncertain. The recently completed DAPT study randomized 10,000 patients who had received an FDA-approved drug-eluting stent, had already completed 1 year of treatment with dual antiplatelet therapy without having ischemic events, repeat revascularizations, or major bleeding, and had shown a high degree of compliance with that year of therapy. The patients were randomized to receive an additional 18 months of either continued dual antiplatelet therapy with aspirin plus a thienopyridine, either clopidogrel or prasugrel, or with aspirin alone. The co-primary endpoints were the incidence of stent thrombosis and a composite of death, MI, or stroke. As compared with aspirin alone, dual antiplatelet therapy resulted in a 1% absolute risk reduction, a 71% relative risk reduction in in-stent thrombosis, and a 1.6% absolute risk reduction, a 29% relative risk reduction in major adverse cardiac and cerebrovascular events. The rate of moderate or severe bleeding was higher in the dual antiplatelet group. At the 33-month follow-up, all-cause mortality was 2.3% in the thienopyridine arm, as compared with 1.8% in the placebo arm. This appeared to be driven by a higher rate of non-cardiovascular death that was accounted for by differences in major trauma associated with bleeding and in cancer-related death. The central conclusions of the DAPT study were that dual antiplatelet therapy continued for an additional 18 months, reduced the risk of in-stent thrombosis and major adverse cardiac and cerebrovascular events, increased the risk of moderate or severe bleeding, and increased non-cardiovascular mortality. While it doesn't offer an easy answer, this much-awaited trial adds important data to inform individualized decisions about the optimal duration of dual antiplatelet therapy for patients with drug-eluting coronary stents.